Welcome back. I'm Dr. Josh Garibaldi, and this is part 2 of our IgA Nephropathy series, a follow-up to our recent webinar and to part 1, where we explored the biology and diagnosis of IgA Nephropathy. Today we shift gears into the practical world, how we manage this disease, how KDIGO 2025 updates are shaping practice, and what lies ahead as new therapies enter the landscape. With me again are Dr. Yelena Drexler, Associate Professor of Clinical Medicine at the University of Miami, where she also serves as Director of Clinical Research in Nephrology and is a recognized expert in glomerular disease. And Dr. Mark Richards, a nephrologist with Florida Kidney Physicians, where he leads the Glomerulonephritis Center of Excellence in Boca Raton. Last time we set the table, now we're digging into the main course. KDIGO's 2025 clinical practice guidelines for the management of IgA nephropathy makes it clear that supportive care, RAS blockade and SGLT2 inhibition, for example, should remain the backbone of IgA nephropathy management. Dr. Richards, how do you decide when to start or escalate these therapies in your patients?
Hello again, Josh, and thanks for having me. So certainly, just like as in any patient who has any kidney disease, whether a glomerular disease, IgA nephropathy specifically, or just chronic kidney disease from hypertension or diabetes, supportive care is certainly paramount. And ideally, just like with any of our patients, we want our patients to have as low a level of protein in the urine as possible. And that can be accomplished just through general antihypertensive control, as well as specifically through the use of renin-angiotensin-aldosterone axis blockade, specifically with ACE inhibitors or angiotensin receptor blockers. And so pretty much in any of my patients who have IgA nephropathy, I will use these agents to help lower proteinuria, hopefully as low as possible, ideally below 0.3. Also, I want to make sure my patients have good blood pressure control. If that alone isn't sufficient, I will certainly utilize SGLT2 inhibitors, which have been shown to be effective for IgA nephropathy patients based on a subset of data from the DAPA-CKD trial that was in the New England Journal of Medicine a few years ago. And then more recently, there have been the development of both dual-acting endothelin receptor and angiotensin receptor antagonists, as well as standalone endothelin receptor antagonists that have also been shown to be an additional complementary piece to add to the standard of care for foundational management of our patients with IgA nephropathy.
Thank you, Dr. Richards. So proteinuria remains one of the strongest predictors of outcome, and KDIGO sharpened its thresholds, aiming for less than 300 milligrams per day as ideal, and less than 500 milligrams per day at a minimum, with levels greater than 500 milligrams per day signaling higher risk. Dr. Drexler, what challenges do you face in monitoring proteinuria and hematuria over time, and how do these KDIGO targets shape your practice?
Absolutely. Thank you, Josh, again for having me. So once we identify patients with IgA nephropathy who are at risk of progressive kidney function loss, I think really defining a treatment goal is the next crucial step. And so the ultimate goal is to slow the rate of kidney function decline, ideally flattening the GFR slope. And the reality actually is sobering. Even with maximal supportive therapy using RAS inhibitors, high-risk patients with persistent proteinuria above that 0.5 gram per day threshold may still lose between 4 to 6 ml per minute of GFR every year. And because proteinuria remains the best and only validated early biomarker of prognosis, our goal should be to monitor and reduce proteinuria as much as possible. The lower, the better. And the 2025 KDIGO guidelines, they do emphasize a target of less than 0.5 grams per day and ideally below 0.3 grams per day, since achieving those levels is strongly associated with long-term stability of GFR. And if we can slow the rate of eGFR loss to less than 1 ml per minute per year, which is the normal physiologic rate in adults, we can give our patients the best chance of maintaining stable kidney function and avoiding kidney failure in their lifetime. Now, when we think about the therapeutic approach, we need to consider two aspects of treatment simultaneously. And this, again, is highlighted in the 2025 KDIGO guideline. The first is to manage the IgA nephropathy-specific drivers for nephron loss, namely preventing or reducing IgA-containing immune complex formation and the resulting immune-mediated injury. And the second is to simultaneously manage the generic responses and consequences of IgA nephropathy-induced nephron loss. So now, as we follow patients over time, we also have to be aware that increases in proteinuria can either reflect ongoing immune-mediated injury or irreversible glomerular scarring. And actually, hematuria can be intermittent And so that is challenging for following patients as well. So I think the takeaway there is when we do see a significant increase in proteinuria or a sharp decline in eGFR, a repeat biopsy may be needed to distinguish between inflammation and chronic damage and to determine which treatment approach will be most beneficial for our patients.
Thank you, Dr. Drexler. At the same time, we're entering a new era. Therapies targeting APRIL, complement, and endothelin pathways, for example, are all under investigation or newly approved. Dr. Richards, which of these pathways do you see as most exciting for changing patient outcomes? And how soon might they influence routine practice?
So to be honest, Josh, all of them. On the previous release of the KDIGO guidelines in 2021, all we basically had were give your patient an angiotensin receptor blocker or ACE inhibitor. If the proteinuria suggests it's at high enough of a level where they're at high risk of progression, you can blast them with systemic corticosteroids. Or if you're lucky, you can try to enroll your patient in a clinical trial. And look at the difference between the 2021 guidelines and the 2025 guidelines. We now have a number of novel agents that attack different pathways that can help delay the progression of GFR loss in our IgA nephropathy patients. Another reason to be excited is that this guideline is already obsolete in and of itself. Since this guideline highlighted, obviously, I think it did a great job of noting that we have to both manage the IgA-specific drivers for nephron loss as well as generic responses to chronic kidney scarring. Already, newer approved agents such as complement inhibitors or standalone endothelin receptor antagonists are nowhere to be seen on these guidelines as they've been approved very, very recently for use in our IgA nephropathy patients. And really, so again, all of them are super exciting. We know that when you switch in ARB to a combination dual acting endothelin receptor and angiotensin receptor blocker, we see improvements in proteinuria pretty quickly, as well as delay in GFR decline. We've also noted the same thing with targeted release corticosteroids. And we now have seen it with some of the newer pathways, such as complement inhibitors, which are also available for use. As we know, 90% of patients with IgA nephropathy have some amount of complement deposition on their kidney biopsies. And obviously, the specific approach or analysis of B-cell targeting therapy, specifically APRIL and BAFF, which are known to increase B-cell proliferation and subsequent release of galactose-deficient IgA1 molecules, certainly represents a very, very appealing target to hopefully add to these other amazing therapies that are out there that we can use for our patients.
Thank you, Dr. Richards. So, of course, even the best therapies are only useful if patients can access them. Cost, logistics, and adoption can be real barriers. Dr. Drexler, from your perspective, what are the biggest challenges to integrating new IgA nephropathy therapies? And how can collaboration between academic and community centers potentially help close these gaps?
Now, this is such an important point. We're entering such an exciting era with new targeted therapies for IgA nephropathy, as Dr. Richards described. But translating those advances into everyday practice isn't straightforward. The biggest challenges remain access and cost, as well as awareness and adoption. And it really starts with identifying patients early. We need to look for proteinuria, hematuria, or declining eGFR, and then confirm the diagnosis with a kidney biopsy. We have new FDA-approved treatments for IgA nephropathy, with many more in the pipeline, but a biopsy-proven diagnosis is essential for patients to be able to qualify for and access these therapies. And I think this is where collaboration is key. Academic centers can play a role in generating and disseminating evidence, running clinical trials, and providing referral pathways for complex cases. Community nephrologists are critical for identifying patients early, initiating therapy, and ensuring long-term follow-up. So when we build stronger networks between academic and community practices through shared care models, education, and outreach, we can lower barriers, we can streamline access, and ultimately make sure patients benefit from these new therapies, no matter where they receive care.
Thank you, Dr. Drexler. IgA nephropathy care is changing rapidly, and the next few years could look very different from today, as you both have already alluded to. So for both of you, if you had to give clinicians one piece of advice on what to watch for in the next 3 to 5 years, what would it be?
So I think the big thing is just keep up with podcasts like this one, ASN publications that can be distributed monthly or even daily on emails I receive. And also with just keeping up with the literature, looking for newer articles that are released regarding therapeutic management in IgA nephropathy. I think the recent KDIGO guidelines that have been released also show the importance of combination therapy. Whereas now that we have all these agents, potentially using a couple of them in tandem can be the most effective way to help keep our patients off of dialysis and away from end-stage kidney disease. And this field is changing. Just stay alert and, let's help make our patients better.
Yeah, so I would echo this. I think it's an extremely exciting time, and my advice is to recognize that the treatment landscape in IgA nephropathy is already changing and poised to change even more dramatically over the next few years. We can hope and expect that multiple new therapies will be approved that target novel pathways from B-cell modulation to complement inhibition. And these advances have immense potential to completely transform care and significantly improve outcomes and improve the lives for our patients with IgA nephropathy.
Thank you both. And that brings us to the end of part 2 in our IgA Nephropathy podcast series. Huge thanks to Dr. Drexler and Dr. Richards for sharing their perspectives. And thank you for tuning in. Stay connected with FSN and nephew.org for more conversations like this. And until next time, take care.